Hello, everyone. Welcome and welcome back to our last session for today on moving past the prescription, addressing women's complex needs for pain management with Lindsay Wolfson. This session will provide an overview of the resources developed to respond to women's need for healthcare providers and policymakers to have a better understanding of women's experiences of chronic pain and the impacts of opioid use for women who live with chronic pain. Once again, please engage with our speaker by sending your questions through the Q&A function, and we'll do our best to answer them by the end of the presentation. If this is your first session for today, welcome. My name is Alvin Kamshum. I am one of the steering committee members for the PTPT conference, and I too live with chronic persistent pain. I'm coming to you today from Edmonton, Alberta, located within Treaty 6 territories and within the Métis homelands and Métis nations of Alberta Region 4. We acknowledge that this is a traditional territory of many First Nations, such as the Cree, the Dene, the Stoney, the Saulteaux, the Blackfoot, and I am truly grateful to live, work, connect, learn, and grow on this land. Now, please help me welcome our speaker, Lindsay Wolfson. Lindsay is a women's health consultant and sex educator. She works as the research manager at the Center of Excellence for Women's Health and is pursuing a Master of Social Work from Wilfrid Laurier University. Lindsay has lived with pain for over 15 years, having experienced migraine and endometriosis. I am sure Lindsay will do a better job at introducing herself and sharing herself and her work with us. Now, over to you, Lindsay. Thank you.
Thank you so much for such a kind introduction. I'm just going to pull up my slides, but it's such a gift to be here speaking at a conference that is by people with chronic pain, for people with chronic pain. And so I'm going to start us off with a bit of an introduction, talk about what chronic pain is very briefly. We know what it is, why some populations are disproportionately impacted by pain, and then what multidisciplinary supports are available. Before I begin, I want to acknowledge that we are joining from diverse ancestral traditional territories of Indigenous peoples across Turtle Island. I acknowledge the First Nations, Inuit and Métis, as the first inhabitants and traditional custodians of the lands in which we live, learn, work, and play. I am joining from the traditional territory of the Anishinaabe, the Wendake and Winsentio, Haudenosaunee, Mississauga, and Mississaugas of the Credit in what is now known as Toronto. This photo here was taken while I was in Yellowknife on Chief Dry Geese territory as part of a project about women's chronic pain and prescription opioid use that I'll be talking about today. And I just want to give my greatest thanks and put my hands up in the air in gratitude for the women that contributed to this project, including the Indigenous women who contributed their voices and their stories. I also want to pause before I begin because yesterday Justice St. Clair entered the spirit world. He devoted his career to justice, reconciliation, and equality. And his work on the Truth and Reconciliation Commission was really quite formative to my own work. He brought to light the experiences of residential school survivors and fostered calls to action so that way we could have a more inclusive future. So I just want to pause and reflect on his legacy and how we can further contribute to reconciliation. Now, Alvin, you did a great job introducing me. I don't think I'm going to say more about who I am, but I do want to start talking a little bit about my pain journey. And one thing you'll notice as I go through these slides is that some slides will say the Center of Excellence for Women's Health because they were created as part of my work as the research manager there. Some slides will say Sex and Spoons, which is my work as a sex educator. And that is really dedicated to supporting people with chronic pain, navigating sex and relationships. So you will see different logos at the bottom, and that I guess is the closest to my disclosure statement that I can make. So many of us have gone through pain journeys, and so this is, a very abbreviated version. And, I think I said in my bio that it's been 15 years. I think it's actually been closer to 20. And there's something quite surprising about being the person at 14, 15 years old who missed school, or being the person who missed their wedding, um, who then, a decade, 2 decades later gets to present to other people about chronic pain. My chronic pain has been a journey like many of ours have. And I continued to work and I continued to be in school. And in 2021 and 2020, my pain was the worst that it's ever been. I have endometriosis, as was said, and before my diagnosis, it was quite debilitating. And I really struggled to complete basic tasks, and I struggled to walk. And it was a little bit fortuitous that at the time, Health Canada came out with some funding around chronic pain and substance use, and that the Centre of Excellence for Women's Health applied for funding. And so while my pain journey started much earlier, that's the starting point of today, 2021, when we embarked on this project. So, what is chronic pain? Why does it show up disproportionately in certain populations? And what does it mean when we talk about comprehensive pain management? I think many of us have seen this definition. It's from the IASP, or the International Association of the Study of Pain, and really emphasizing that pain is a sensory and emotional experience that is associated with or a result of actual or potential tissue damage. And it can serve as a warning symptom for a medical condition, or it may persist despite the management of the condition that initially caused it. And when we talk about chronic pain, we are talking about pain that persists or recurs for over 3 months. And this can just become the predominant or sole clinical problem in some patients. And as the Honorable Minister said yesterday, in Canada, 1 in 5 people experience chronic pain. And we know that pain is multifactorial. We have the biopsychosocial factors that contribute to it. And I think that for this presentation, you'll hear me say biopsychosocial more than multifactorial, because I'm not a clinician, but they both in this case are meaning the same thing. And I think that's something really validating that's happened in pain research in the last few years, is that the World Health Organization now recognizes chronic pain as a disease. And it's not just a symptom of something else, because I think that for all of us who experience chronic pain, just that recognition that chronic pain is that disease is so powerful, and it holds so much strength, because what we're told causes chronic pain is anatomy and physiology, but what actually causes chronic pain is much deeper than that. And I don't think that we can fully understand chronic pain and how we can manage it without thinking about the biopsychosocial nature and how that can contribute to the disproportionality of pain. In Canada, chronic pain is most common. It is the most common reason, sorry, for people to seek healthcare. And with many chronic illnesses, chronic pain is not distributed equally. I've put on the slide here a couple of populations who are disproportionately affected by pain. Those were identified through the Chronic Pain Task Force reports. But I've also included this infographic here that we created at the Center of Excellence for Women's Health. And I just think this infographic is really important, because we know the challenges with seeking pain management, and we know these sort of gendered interactions that happen when women are help seeking. And we're told so frequently that it's all in our heads, but we have the evidence to show the ratio of TMJ disorder is 9-1. Women experience it on a 9-1 ratio compared to men. 10% of women and an unknown number of trans and gender diverse folks have endometriosis. And this says of reproductive age, but we're seeing research that is showing endometriosis showing up much earlier. That 80 to 90% of people who've been diagnosed with fibro are women. These are real statistics. And so this isn't just in our heads. And so as we talk about the complexity of pain, it's really important to understand that there are real life sex and gender implications. And that's why we're seeing these differences. And these same differences have an effect on how we manage pain. So I'm not going to go into a lot of science, but a little bit of science. This is another chart we use a lot at the center, and it's a slide that was created to understand the sex and gender related factors affecting pain. And I know it's really small on your screens. But when I talk about sex, which is on the left, I'm not just talking about our anatomy. I'm talking about our hormones, our genes, our physiology and anatomy, and our neurobiology. And the reason that I make a really clear distinction about sex is for a few reasons. One, we do see these differences in hormone administration. We also see there are different physiological mechanisms that contribute to females experiencing greater amounts of pain. But the other reason I talk about sex is because for gender diverse and trans folks who are seeking pain management, and perhaps they're not on T or they haven't had gender affirming surgery yet, they are still going to experience these sex related factors. And so it's really important that we don't lose our assignments at birth and our sex, because it does tell a lot about our pain stories. On the right, similarly, we see a lot about pain. We talk about gender, and it's not just our gender identity. It's also how pain interplays with our roles, our relationships in our institutions. And, one of the examples that I pull out, which is related to gender identity, is how chronic pain can impact the perceptions of femininity and masculinity, an individual's sense of their own gender. And I talk about this a lot in my personal work about how chronic pain takes so much from our bodies that, this perception of our body then belonging to a gender can be really challenging. And so, what is that interplay? How do we think about these issues? We can't just think about our identity, but also our relationships in when we're seeking healthcare provision, our personal relationships, things like this. So, these all interact with our experiences of pain. And of course, we see how pain manifests among people with further intersecting identities. And I've pulled one example from a Canadian study, which looked at the relationship between experiences of pain, discrimination, and stigma among people that identified as Indigenous, LGBTQIA2S, and refugees and newcomers, which are three populations that we know experience high levels of inequity, discrimination, stigma, and pain. And here, participants really talked about how their identity is perceived can impact what treatment options they have and their physical safety. And many believed that their pain was associated or emerged from traumatic experiences. And so I think this is really important for us to think about in terms of how we talk about the management and treatment, because if you don't feel safe in even accessing care, then your treatment modalities are going to look very differently than somebody who does feel safe showing up in their healthcare provider's office. So that's a little bit about the disproportionality. I'm now going to share some of our findings from our research from this Health Canada funded study, and this was about women's chronic pain and prescription opioid use. And you can see here that central to research evidence, healthcare provider practice, and educator experience, we held the perspectives of diverse women with lived and living experience of chronic pain and prescription opioids. And it was a really big gift. Myself and one other person with lived experience were the primary staff on this project. And so it was also experientially led. We started off with the project doing a literature review, but we also did interviews to really understand um, the experiences of women who were using prescription opioids for chronic pain. And you can see here we interviewed 22 women. This was from 3 regions. The project initially started as being focused in the Northwest Territories, Yellowknife, and BC. Women ranged from 28 or 25 to 80 years old, and they used opioids for as little as 1 month and as long as 24 plus years. A third of the women used prescription opioids for over a decade. And when we looked, there were 31 primary conditions that were reported that prompted their prescriptions. This could have been accidents, fibromyalgia, SI joint dysfunction, but there were a lot of co-occurring conditions like migraine or undiagnosed conditions like endometriosis. So if we say 31 primary conditions, let's multiply that. And that's really the pain that people were experiencing. And 9 women were still using their prescription opioid at the time of the interview. I'm going to quickly go through some of the themes that we found, because again, I think they have a really big impact on um, the moving past the prescription, what it means for pain management. And so the first was all about balancing benefits and harms. We saw that the benefits increasingly outweighed the harms, that the improved mental health that people experience, the increased quality of life, the pain relief, and a lot of that was attributed to even having an option for pain management. And most women found the benefits far outweighed the harms, despite knowing the risks of dependency, constipation, drowsiness, adverse mental health, and stigma. Just having that pain relief was so unbelievably profound. And we have one quote here from a woman with fibromyalgia who said, "I think I shed a tear when I get some actual pain relief. Anytime I have a really good pain relief from something, it's usually emotional, but in a good way. I just felt like I could do things. I felt a little higher drunk, if you will, but I was, oh, wait, I can do things. I can go run some errands and not be hating every second of this. But also, oh, this is good pain relief." And I think really, while this wasn't named, it comes down to the effects of chronic pain on our bodies. Chronic pain isn't just that physical health, it is our ability to sleep, socialize, go to work, go to school, our relationships, all of these. And, I've pulled these slides from a Spoonie influencer um, because I think it's just really well done. But the other thing she articulates here, and a word that we didn't hear in our interviews, but certainly was expressed in a more implicit way, was around the notion of grief and how that is shared and how that is experienced. And I think that really contributed to the continuation of opioid use, but also the feelings that were shared during these interviews. Another theme we heard a lot, I'm sure this is not surprising, is stigma. Stigma related to prescription opioid use, stigma related to chronic pain, stigma related to physical health, mental health, gender, ability level, class, race, ethnicity. There were mounting stigmas that people experienced. And it was from family, it was from friends, it was from health and social service providers. There was nowhere that people could turn that didn't have sort of the stigma laden place and space. With healthcare providers, many women describe being made to feel as though they were drug seeking rather than experiencing legitimate pain that requires treatment. And those, of course, were heightened among those that were seeking additional intersections of oppression. So among Black and Indigenous women, women in rural, remote northern communities, pregnant and parenting women, LGBTQIS2 plus women, and women who were underemployed, unhoused, or had disabilities. And given the biopsychosocial nature of pain, these experiences are quite significant because they can perpetuate and worsen women's pain. They can impact her ability to access pain management or create a pain management plan in the first place. And it also affects the trust in her providers. Women may experience high rates of chronic pain because stigma just limits her access to get that prescription in the first place or any other pain management strategies. And despite the negatives, women also really felt compassion for their healthcare providers. They understood that the opioid crisis has put a lot of pressure on providers to limit prescriptions and reduce their patients' opioid medications. And for some, especially those that were accessing opioids as a last case scenario, that was really difficult. But there was also a lot of understanding that this is sort of the context in which we're operating in. And so what emerged is this concept of self-advocacy, and that women were seeking information themselves because they didn't see that it was provided. They were seeking information about what their pain management plans could include. And yet they really wanted information because they didn't feel like it was available. And so, where we ended in the interviews was this desire for alternatives. What does it mean to move past the prescription? But also, how do we get information about how to safely use opioids, what the side effects are, risk of dependency, and additional pain management strategies? And so, that's the starting place for the rest of the presentation. What we heard women wanted. And none of these are clinical guidelines by any means whatsoever, but they're just educational information that hopefully you can walk away with. So the first resource I'll walk through is this one that we created for women living with chronic pain. At the end of the presentation, you'll get two links. One is directly for this resource, the other is for our website. In the end, we created 13 resources, two of which I'll talk about today. And I start with this one because it's the resource that was really created specifically for women who experience chronic pain. And you'll notice that we start off with that infographic once again, because again, I really think it holds power. We've walked through medical systems not being believed, but it's really hard to fight these statistics. So if that's where we start, we then talk a little bit about sex and gender, because again, I think there's this lack of understanding of how um, all of the sex-related factors and how all of the gender-related factors impact our experiences of pain. And then we walk through 8 evidence-based pain management strategies that are for women's chronic pain. And some of the strategies you might have tried before. Others might be new to you. And they're laid out on 2 pages where you can learn more information about each of the strategies, what it is, and what it can be helpful for. And a lot of these can be used in tandem. And I think that's what's really special about pain management, and something that isn't told to us, or certainly has never been told to me, is that we can create pain management plans that cater to our unique needs, our financial circumstances, our chronic pain experiences, and the availability of services in our area. We can create plans that are custom to us. And so, what is great also about these strategies is that, with the exception of 2, no diagnosis is required. So, for folks that are in that limbo period, which is a really hard period to be in, a lot of these strategies are ones that people can just employ. The most evidence-based strategy for chronic pain management, the gold standard in chronic pain care, are interdisciplinary pain programs. These might include education, physical, or other management therapies. They are bringing together different health disciplines to address the comprehensive needs and really attend to the biopsychosocial nature of pain. And we do see the evidence for these. We see that they're helpful in developing coping skills, improving mental health and mood, functionality, mobility, and reducing pain. And earlier today, I was listening to a webinar from TAPME, the Toronto Academic Pain Medical Institute, and they also talked about how their program reduced isolation and the feeling that so many of us with chronic pain feel, that notion of being alone. So I think that's a really profound thing, that a lot of interdisciplinary pain programs also do include social support elements, and so we can build connection that way. The next pain management modality is the prescription. It's not moving past it. And, when we're thinking about prescriptions, we started off this project talking about opioids, but there are lots of different prescription medications that are out there for folks with chronic pain, including opioids, anticonvulsants, antidepressants, and that the choice of medication really depends on the nature and intensity of pain as well as individual health considerations. And um, while our study emerged from this work on prescription opioids, we also recognize and have created this sheet that includes and considers the impact of dosage, sex, weight, other factors. And I'll note that while opioids are most effective in a short-term capacity, for people who can't find relief elsewhere, let's think about what we can add to the equation. So we're not just relying on one thing for our pain management, but we're building this sort of wraparound approach to reducing our pain. There are lots of lifestyle interventions, and what's great about lifestyle interventions is that they can be free. They can cost lots of money depending on the journey that you go on. And I'm pulling out exercise here, and I think that often as clients, we hear, or patients, we hear like, you should exercise. And there have definitely been times that I think I maybe out loud, but hopefully internally have said like, how, or great, I'll exercise and then my pain will be worse, really filling into that pain catastrophizing. But the reality is, what is effective for people in terms of exercise, just like what's effective in terms of diet, is unique to each person. I often see in terms of exercise, and I think a lot of this has to do with the work that I do being related to conditions where hormones are affected, is that yoga and strength training are often recommended because they don't increase cortisol the same way that a high intensity interval training would, or that running would. Another exercise we heard lots about in our interviews was pool walking, because it was kind to the joints, but it was a great form of resistance. And all of those can be quite affordable depending on what area you're in. And exercise can be helpful for improving mobility and strength and reducing pain, but it also can be helpful in improving our mental health and mood. And I think a lot of that has to do with what happens when we build strength, and also we build self-efficacy, and we can see that something we're doing affects change. It's so positive. Um, it's quite complementary with these physical and manual therapies like massage therapy, like physio, chiropractic, trigger point. They can all be really helpful in improving functionality and mobility, but also give, with trusted care providers, you get these safe movements that people can do at home and build confidence in our bodies. And I think that's a piece that is so missed, is what it means to have confidence in our bodies. These last few slides are ones where I think a little bit more stigma in the pain community may emerge. And I'll start with psychological supports. And yesterday, Dr. Michael Yellowbird talked about decolonizing mindfulness. But for those who weren't able to attend and hear about the traditional ways in which mindfulness emerged in Indigenous communities, really thinking about mindfulness as the practice of maintaining awareness and attention to the present moment, You're fostering a non-judgmental attitude and accepting attitude towards one's thoughts, feelings, and bodily sensations, including pain. And mindfulness is a bit different from cognitive behavioral therapy because of its emphasis on acceptance. And unlike cognitive behavioral therapy, which is structured and goal-oriented, and that's the emphasis there, we can look at how we're changing thoughts, behaviors, beliefs. There has been a lot of research in both the mindfulness and psychotherapy fields, just demonstrating how useful these both are in pain management. And I think that part of the stigma that emerges is because, again, we go to healthcare providers and we hear it's all in your head. We're told, oh, you're a little anxious, or oh, you're making that up. And so it just creates this different shift. But if we realize and consider how pain is very stressful before you get a diagnosis, if a diagnosis is something you're seeking, it is really hard to navigate. And that stress and anxiety, the grief of pain, all of those exacerbate. And so if we see psychological support as one way that we're taking care of ourselves, we can reduce the pain, reduce pain-related distress, find healthy coping strategies. And I use that word healthy, but that's really a subjective term. And we find ways to relax that don't exacerbate our pain. And you'll notice that on the top here, I've put a book from Dr. Lori Brotto on the screen. Her team at the Women's Health Research Institute has done a lot of great job putting mindfulness on the map. And along with her book, she also has a workbook. But of course, there are resources that are available out there. I know Power Over Pain has lots of resources about mindfulness that are not about sex, but as a sex educator, I had to. In my last few slides, I'll talk about some other pain modalities, and then we'll get into what it looks like to actually find this care now. So one of the other pain modalities we see, and I know there's a talk on Thursday, I believe, about cannabis and opioids, but we really have heard both in our work on this project and also our work at the Center on Sex, Gender, and Cannabis that women are using cannabis increasingly for chronic pain. And we see research, Australia has really done a great job on publishing research around cannabis and pelvic pain. This study is from Mike Amora's lab, which looked at cannabis for this self-management of endometriosis. And again, I think this is pretty small on your screen, but if you look at the colors, green means significant improvement, which is a 50% reduction in severity or duration, and yellow is moderate, so a 25 to 50% reduction in severity and or duration of pain. And you can see that there's a lot more green and yellow on the screen. So we're seeing that cannabis in this population of women, so women with endometriosis in Australia, that cannabis was really effective in managing sleep. It was really helpful in managing nausea and vomiting and in depression and anxiety. So we're seeing it a lot for symptom management. And if I pull back to our work at the center, we have seen that women use cannabis. The most cited reason for why women use cannabis is for pain management. Women have reported it being effective in managing pain and inflammation, improving sleep, reducing nausea, vomiting, and cancer-related symptoms. Cannabis also is reported in helping multiple conditions, including migraine, endometriosis, PCOS, epilepsy, and headaches. And from both Dr. Amore's lab and also our work at the center, we're really seeing that women have been emphasizing that the perception of cannabis, that cannabis is safer. They perceive cannabis to be safer and having fewer side effects than prescription opioid medications, and that women are more likely to use cannabis to discontinue or replace their medications like opioids, antidepressants, benzodiazepines to help manage their pain and other health conditions. So, really interesting how we're seeing the shift um, in substances. In our interviews, we also saw a lot of women that were using alcohol to cope and using other street substances to cope. And so there's lots that we're seeing around substance use and pain and use for varying reasons. The last strategy I'll most explicitly talk about is time. And as a self-declared spoonie, I think that this is a really controversial one. There is research that shows that time can be an effective strategy in reducing chronic pain. And it could be because of healing, pain, building coping strategies, building acceptance, or finding other self management. And what I find really interesting about this notion of time is that I agree. Time absolutely can help in all of these different ways. But for people who are seeking a diagnosis or don't understand their pain, time can feel the exact opposite, and time can feel like it worsens our pain. And so some of these modalities that I shared can be really effective in managing pain and can be really effective in managing pain for you. And they might also do the complete opposite. And it is all about finding the strategies that are most effective for you that fit into your life. Those were just the ones we covered in our worksheet, but it doesn't negate that there are other pain relieving modalities that are out there. Heat therapy, I know I probably have 3 heat packs behind me. Acupuncture and acupressure, other lifestyle modifications, land and culture-based exercises like smudging, going on the land, eating traditional foods, eating foods with people you love, surgical management, all of these can be additional pain relieving modalities. And so I think that's really important that we hold that biopsychosocial consideration when we are building our pain plans and when we're working with providers to build them. So, where our sheet ends is a reflection. What pain management strategies have you tried? What were the benefits and what were the drawbacks? Are there any that are new to you and of interest? And what are some questions that you have for your healthcare provider about the pain management strategies? And I hope this is a useful reflection that we've included on the back here, because what our pain journeys, like my pain journey that I showed at the very front, it's not linear. And what worked 5 years ago might work great today, but maybe didn't work back then. And so having that time and space to reflect on what worked, what didn't, what was the context, we hope will be really useful for you. The last thing I'll say before we go into Q&A is around trauma-informed support. I know there's been a lot shared in these last 2 days already about self-advocacy and having patients go to their providers. And we created the sheet about finding trauma-informed support because it is not as easy as going to a provider at all times. And so what does it mean to find a provider that you can build this connection with, where you feel like you have choice and collaboration in your pain management, where you feel safe, and where you're building on your strengths and skills? Because there is no stronger person than a person who has experienced chronic pain. We know what our bodies can do. We know these things. And so how we can work with providers that validate that. And Dr. Jen Gunter, in her book Blood, said it so perfectly. Spending time with a practitioner who listens and validates experiences is in itself an intervention. And I think we really need to hold on to that. So as we leave today, what does all of this mean? The best pain management strategy is the one that works for you. It attends to our biopsychosocial needs. It can reduce instead of masking our pain. It can help us build healthy coping mechanisms and build on the strengths we already have. Our best pain management strategies help us identify patterns of events that result in flares or triggers, and they help us find our most fulfilled life. There is no world in which I could have imagined 15-year-old me who missed school, or that person who missed her wedding would be here today talking to other people with lived experience as a person with lived experience. We can find strategies that work for us, and it is our journeys to walk on. So thank you so much. It was such a joy to chat with you today. And I think there are some links in the chat, but if you want any of our resources, you can scan the QR code here.
Thank you. Thank you. Thank you, Lindsay. I love how you ended this. You said it is our journey to walk on and we can find strategies that work best for us. That is so true because what works for A would not necessarily work for B.
Yeah.
And you know what? I don't only live with chronic pain myself, but take a look, I'm a woman. And aside the other things I've been diagnosed with, I've also been diagnosed with things that are only peculiar to women. And you did say something about, most times hearing things like it's all in our heads, which is so true. And in cases like, let's say, for example, with endometriosis or fibroids, you also hear things being told like, oh, menstrual pain, it's normal, it's common. So
Yeah.
what would you say is the reason why many women get diagnosed after several years of living with symptoms? Is it that there is not enough research on these health situations, conditions, or what could be the reason?
Oh, I think there are so many reasons. I'm not going to be able to share all of them, but I'll do my best at saying some of them. When we think of our health system and our health research, men were used as the marker. So all of our studies were based on men, and that was until about 3 decades, maybe 4 decades ago. So we don't have the research. And if we're looking at historical, it's not there. Piecing into that is it also means that we don't have the research on conditions that show up more among women and females. So there has now been a huge push in Canada for endometriosis related funding, for instance, but that funding has just really emerged in the last 3 years. And so I think there is now a really big priority that we're seeing, but I don't think historically it was there. I think that also the construct and like the gender construct really plays into it, where there's this perception of women as weak. And that if that's the stereotype we're basing things off of, which
Mm.
from a factual, like if we're looking at the evidence, that is not, those are not facts. But if that is the social construct, then absolutely there's going to be delays to diagnosis because women are making their pain up. But that's not the reality. Women aren't just making their pain up, they're experiencing pain. It shows up differently. And the last is that there are so many different interplays, especially if I think about endometriosis and fibromyalgia, the two examples you asked about or used as your examples. The symptoms for them are exhaustive. Most people with endometriosis don't find out that they have endometriosis until they're trying to get pregnant. So if you show up and you have menstrual pain, or you have problems walking, or you have bloating after eating, all of these things, well, there's a myriad of conditions that could be. And if your diagnostic guideline is surgery, which that has been the gold standard for endometriosis, you need to wait till a surgery bed is available. So you're just going to exacerbate these wait times, and you're just going to sit in limbo. And even my surgeon, when I went in, she's magical, she's wonderful, and we both knew that I had endometriosis. As she was wheeling me in, she said, "Today we're going to find out if you have endometriosis." And I sat there and I was like, what if I don't? Like, oh no. And so, what does it mean when those are how we diagnose people? It creates a lot of these really long delays. So, a few reasons, but a couple to start us off.
Thank you. Thank you for the answers, Lindsay. Our next question, is there somewhere, not behind a paywall, that we can access the research paper you spoke about?
Um, the one from Mike Armour, I believe it's open access. If it's not, anyone can contact me and I'm happy to provide it. Also, we will be publishing on the study that I spoke about, and it will be open access, so everyone will be able to access it, and we'll put it on our website.
Thank you. And I'm going to, these are actually two separate questions from the same person. So I'm just going to, from Zana. And the first is, why are you distinguishing between females and women? I think that came up at the beginning of your presentation. And the second question says, only 22 women. This is less than 0.01% of the population of women in pain. Is this information being used for decision-making purposes? As a comment, I hope not.
Great questions. I think I'm going to go to the second question first about 22 women. So in qualitative research, we have this thing called saturation, which is if you hear themes that come up and you're getting sort of the similar responses and your themes are fully reached capacity, that's considered saturation. It's really common in qualitative research to have low numbers. The findings cannot speak to the entire population of women who experience opioid or experience chronic pain and use opioids, but they give some inferences. We also did a literature review that was inclusive of both qualitative and quantitative research. And so we would have captured a much larger population of women to reflect the data that we're presenting. But that's a really great question. To the one about sex and gender, I use that at the beginning to talk about why it's important we think about, because oftentimes when we think about sex and gender or we think about women, think about females, we're conflating and we're assuming that everyone identifies as cisgender. And that is just not the reality. There are sex-related factors, our hormones, our physiology, our anatomy, neurobiology, all of those that influence pain in a very specific way. And they interact with gender, our gender identity, roles, relations, institutions. And so depending on how you present as a person, you may experience just the sex-related factors that are attributed to female, being assigned female at birth, or the gender-related factors that somebody who identifies as a woman might experience.
Thank you for that answer. Next question, did you find that CBT, ever did harms to people living with pain?
We weren't looking at every modality so specifically. Our research was really looking at what were the chronic pain interventions that were sex and gender informed. So CBT, in our research, we did not see any harms. It is quite possible from, my other hat as a person with lived experience, as a sex educator, as somebody who's studying social work, that CBT might be harmful because it might bring up a trigger. And so absolutely, it is possible. And I think that's why at the end of our resources, we really articulate and at the end of the slideshow, I really articulated figuring out what our triggers are. And if you are going to be with a care provider that evokes those, or there might be a triggering experience that exacerbates your pain, how to manage that.
Okay. Concerning your study results, did you analyze or find something related to harms? I think this is kind of related to the answer you just gave. How can women better advocate for themselves in medical settings?
Ooh, great questions. I think advocacy is really difficult to do because we are put into sort of a precarious patient provider situation where inherently there's a power differential. So, one way you can self advocate is by doing the research. Another way you could self advocate, if you don't feel as though you can be your advocate in that situation, is by bringing a friend that can help you write down notes, bringing a friend who can record it. You can self advocate by recording a conversation, by keeping a journal with you, by bringing a log with you. For the women that we interviewed, I mean, talking about the benefits and harms, we had women that wrote down every single medication they'd taken for the last decade, the time they took it, the dose amount they took. And so they could go to their provider and say, I'm not overusing. This is exactly what I've used. And that was their self advocacy. When I've gone to my physicians, I've written down my entire medical history. That's my self advocacy. It's going to show up differently. Lots of resources available online for different types of chronic pain that will give you sort of like written journals or things, tips that you can use, but our trauma informed support resource would also be helpful, or reflection questions in advance.
Oh, that's a good one because I also someone recently said whenever they have a medical appointment, they write down like they type it down all their symptoms and
Yeah,
every medication they've taken, they print out 2 pages, hand one to the medical practitioner and one for themselves. And I'm actually looking forward to doing that myself because usually I just write them in the book and I just have everything with me. And if there's any medication I'm also currently on, I take it with me. And
totally.
yes, the idea of taking someone with you or maybe recording, that is also something that I've heard before. So, and yeah, just some tips on how we can really advocate for ourselves. So thank you for that, Lindsay. Is cannabis good for women with growing pain?
I am not a clinician. I cannot advise that anyone uses anything. Um, there has been evidence that cannabis is helpful for pain. The way it helps moderate and mediate your receptors. Um, I see it most in pelvic pain. So if groin pain falls into pelvic pain for you, it might be very helpful, also helpful in symptom management and anxiety. And so if you're seeing sort of that mental health correlation with your pain, and if have using cannabis to reduce anxiety might be helpful for the the physical sensation of pain, it could be an option, but I cannot give clinical advice.
That's very understandable, Lindsay. There is a question from Isabel. Can you post the link to the study, please, or the title of the paper?
Okay. The I'll put it in the main chat for the conference right after this, if that works.
Awesome. Next question. I love that you have started with a picture of Yellowknife. I lived there for 4 years and it is one of my favorite places I have lived in Canada. There I have learned a lot about indigenous culture and myself. Oops, sorry. Indigenous culture and myself. I was diagnosed there with fibromyalgia. I advocated for myself for 2+ years and I did a lot of my own research. Sorry, this is a long one. So I did research into drugs. I tried 4 different meds, seemed like they were working, but then I was finding that I didn't like how I felt after taking those. I went to my doctor and asked to be put on medical cannabis, and I started sleeping much better. My pain levels have lowered. Thank you for your time today. I just hope that we can move past the stigma around cannabis. This has been very eye-opening to me. This conference has made me want to help others who suffer with pain. Well, this is actually a comment, so that's a good one. Thank
Such a
you.
nice comment. Thank you.
And there is a question from Shivani. Can you speak more about what the participants shared about using cannabis, length, benefits, harm, if they would recommend it, the main health concerns they were using for?
So cannabis was not shared widely. I'm just trying to like go through the interviews in my head. Um, Cannabis was not a common strategy that women we interviewed spoke about. Um, it was more in the research we've done, both specifically on cannabis and also on um, um, sex and gender related effective pain modalities or pain strategies. What I would recommend you do is I know that our website was linked and we do have cannabis specific resources. And so more information I think would be there than I'm able to share just because it's talking about larger studies than this specific work.
Okay. And have a last comment here from Teresa. Based on my own experience, advocacy equal persistence plus ability to say no. By abandoning a physician and find a new one when a doctor does not listen or learn. Patience and persistence, it is how I was able to build a solid circle of care. Good for you, Teresa. It's always good to know what works for us, and after all, we are the experts in our own pain journey. Thank you once again, Lindsay, for being here. Thank you for sharing your experience, your expertise with us. And thank you to each and every one of you for being here with us today. We really appreciate